Right, so if everybody can hear me correctly, thank you very much for the invitation. I will not present myself again. I try to have a overview of what I'm mainly interested in. How data quality can be analyzed, can be understood, and can be a subject of research itself. Because sometimes or most of the time, data are just a tool for different analyses, and data itself is not the key element of the analysis. And in my understanding, data is a social construct and real world data. And when you have this type of construct, its quality impact the way you are doing different analyses and also the machine learning algorithm you are trying to develop around. So understanding how the data are created and how it's useful is the way to test. So what I want to present here is different tests for understanding the quality of this data. So um, we are on AI because everybody is talking about AI, and it's important to know where is it AI in the health domain and how is it in the health domain, and that's the main context I'm trying to build on. For sure, every analysis is interesting for me. If I have an impact on statistical analysis, it's also something I'm interested in too. But because everybody is interested in AI, I try also to highlight the path between data quality to the AI implementation. So everybody wants to be surprised by AI because this is what we want. We want something that, oh, okay, it's intelligent. We want just to be impressed. We don't want to understand the reality around these deep type of tools. We are not interested in the real intelligence around that. We just want to discuss with something. We just want to have an interaction with a specific tool and just have the impression that its intelligence this is enough for us. But our impression is not enough for the reality of our data. And this is not something new, it's something that starts since the 19. When we have first created the word AI, every time, it's like every 10 years, there's something saying that, oh, AI is we develop something very impressive, we will change everything and so on. And after that, we start understanding that we need to create another thing because it's not working as we described that. But also we have some tools that can appear and people will start to freak out, okay? Because it's too new, is like changing our way of thinking, our way of working, like when teachers do not want a calculator to be around because no, we will not be intelligent enough if you are using calculator. But because people saying that we cannot have a calculator in your pocket, now it's true. I have an impressive one in my pocket every day, so I don't need to be able to calculate. But even right now, my son is still learning how to make an automated calculation because it's interesting for him to have this type of reflection. Now we have LLMs and we are asking the same things. How are we do what is a reasoning for us? Can we rely on these? And how far can we go in their implementation in research, in clinical decision support, and so on? So we have this type of reality. This is a picture before LLMs, okay? Oh, not before LLMs. It's like in the right time of LLMs when we have some big resources being able to generate something. We just need to talk about something and you can create a picture. This is already something impressive. We just need to ask to someone, draw me something and can just draw it. But what is the reality around that? If this is the first result we got, if you talk about salmon, because the only information we have on salmon, and that is used for the training of this model, is what our influencer give to the model with some picture of different plates, and it's what is used for the training and the result. If you are talking about the salmon in the river, that's what we try to generate for us. So the reality of these element that's stating that what we get in the data is what we obtain as an intelligence. It's still what we have because the technicity we have, the LLMs, how they are built, they are only built on the type of data we are using, the type of reasoning we already implemented, and they can only do that. And when we understand that, we need to understand that we need to look into the real-world data quality and see their impact of different algorithm implementation. So we have a reality we try to describe because specific change can totally change the epidemiological reality of a population. This is a study we just published last year, and we just changed the type of classification used for the disease. If you are using the international classification of disease, depending of the version we are using, if you are using the 10 version, the 11 version, or the 9 version, you are completely changing the profile of your population. And you don't need to add anything in addition. It's just the version of the ICD code we are using that impacts completely that's the reason we have a reality in our data we need to better understand and see how they are impacting our reality. We also try to see the performance of LLMs. This is an example of algorithm we are trying to say, okay, if LLMs are able to develop a specific reasoning task, can we just apply them on a specific task like scoping review? So we apply these LLMs on specific step of scoping review. And yes, it's working a little bit. But of course, when you are looking very closer to each step, you are seeing that you need someone around to manage the different error that will appear. So when we have this type of reality, I have a limit of data quality, I have a limit of a different technology I need to apply. I try to decide different way of implementing things. And this is the two main tasks I want to present today. The first task is to automate the grouping of patient reality. And for that is like applying AI for public health domain. And I'm working for Quebec coût par service et son service. It's like per way path. It's a ministry project that try to create a specific way of costing and for this reason, we are trying to see if our data can support our implementation and understanding of the resource that are using for a specific patient. So I don't know if you know what is a diagnosis-related group. It's not work. Okay. A diagnosis-related group is a specific tool used in economy. That's just the relational on this is like if you are a patient, we can group patient based on the type of disease and the type of resources need for taking care of them. And if you have diabetes, for example, we are a specific group because I know the type of resource I need to implement, and I can say that we need the same type of resource, and we will cost something. And if you have a complicated diabetes, I can say that I need more money for you and so on. So we try to create different groups this way. And based on that, we can decide that, okay, if I receive a specific patient, I can depending of the diagnosis, the type of comorbidities the patient can have, I can decide that we are being part of this group, and I can now decide the type of resource and the costing for these when we are part of this group. So the problem is we need to derive this diagnosis-related group from our data, and we do not have data to do that. So it depends. There is different choice to do that because there is the difficulty of creating the group. There is also a difficulty of, based on my patient reality, to assign it to a specific group. When we have these two difficulties, what we have right now is like the Quebec DRGs are coming from Maryland. The government decided to pay the DRG create in Maryland to see if they can use it here. It's like a couple of $1 million they use for buying these DRGs. And now we are trying to see if we can align our patient reality, our way of coding our patient to this group. It's not working very well because the way of grouping and the way of working in Maryland is not slightly different. Slightly is a little slightly, but it's different from what we are doing. So we need to, the alignment is not correct. So what we are trying to do is, can we in ourselves being able to have a data-driven approach, saying that based on the way we are collecting our data, can we group our patient based on their clinical reality to have something more interesting than what we can get by trying to take our patient and try to insert in a specific group that do not correspond to their reality. So that is what we are trying to do. And we try to go further than that. We try to cluster the type of stay, but also try to cluster the patient trajectory. So because it is a government project, we have access to different data, all the data of all patients. We decide to create a specific cohort of population to be sure we can follow up these population in the time and all the is encounter with the health system. And how we do that? We take for each stay, for each hospital stay, we mainly use the stay at CHUM, Centre Hospitalier University of Montreal. It's CHUM data we use to start our cohort construction. So we create for each patient with an encounter for each fracture at CHUM. We decide to extract all the information we can have, the ICD-10 code, BCCI code, the intervention code. We also take different demographic variables, some clinical descriptor that can be interesting for us, and also some administrative characteristic, and also the cost we have right now for this type of patient. So based on that, we decide to cluster our stay, a specific hospital stay, and after that, when we have a cluster, we want to understand if the cluster is clinically meaningful. And we have two choices. We can ask a specific clinician to do that. We are on the project to asking our orthopedists to help us understand the type of grouping we are obtaining. But also we decide, because we want to go faster, to see if we can automate relabeling and if we can compare after that the labeling of our LLM and also the labeling coming from the clinician that we look into the cluster and see this. It's interesting. We test different models, but the one working the best for this labeling pathway, GPT-OSS, that's the reason I just presented. So how we do that? Once we have the cluster of stays, we use this cluster of specific stay, and for each patient and all its encounter for the health domain, we decide to create a trajectory. And we create a trajectory for each patient to see that you have a specific profile where a specific cost of your trajectory, but also all your stay are a specific appartenance to a specific cluster we already create previously. And based on that, what we need to take into account first is the chronicity of ICD code. Because when a patient is diabetic, for example, and diabetes is not important for the treatment, sometimes we are losing the information around the type of, around this chronic disease. But it's important for us to understand the type of comorbidity, to understand also the cost of the type of trajectory the patient can have. That's the reason we try to cluster. We first assign a specific membership of group for our ICD-10 code, stating that 1 is a chronic disease, 2 is a long life chronic condition. Because for now, diabetes, if you are diabetic, is like, well, nobody can cure you. We can try our best to give you a better way of living, but you will stay diabetic, and we cannot change that. And this type of information need to remain for all the encounter of the patient. And based on that, if we are a diagnosis from group 1, we try to make sure that we can carry forward this information from 1 year encounter of this patient to make sure that, because the definition of chronic disease is it need to at least stay for 1 year. It can stay longer, but we cannot go for, because we cannot, it's an automated process. We need to have a minimum requirement to be fulfilled. But if it's longer than that, I'm sorry, we cannot have the information. But you are lifelong chronic disease, so we can carry forward all of this information to all the different encounters. And based on that, we create different comorbidity score to understand the type of relation we can have between the patient. And once everything is done, we first create our grouping of trajectory. I will not come back to that. And after that, create our grouping of trajectories. And this is just a set of machine learning algorithms we use for the groupings. And we test everything we can test. That's what we try to do. We benchmark everything, and based on which one performing the best, we decide just to select. This is a reflection we have, because how to have a specific matrix of comorbidity, how we can have a specific link between the different ICD code we have for a specific person. We have different metrics we can use, and we wasn't sure which one is the best, and the literature did not help us to understand which one can be used to understand the link between the different ICD codes. So we put everything we can have in a specific matrix, and we create a matrix to be able to, of all the ICD code, taking into account different type of matrix. It's exposing a little bit, but we decide that the way we want to do. And based on that, we create our two matrices for each patient, a matrix for ICD code, a matrix for health intervention CCE code, and based on that also, we are able to create a specific this one is for the pathway. When you create, I think the pathway, this one is more interesting. When we have the specific ICD clusters, we use also the appertness to a cluster as a features. We reuse the demographic variable and also all the length of stay for the trajectory and all the cost for the trajectory, and we decide to cluster everything. And based on this clustering of trajectory, we also use LLM to automate the labeling of this trajectory. I will present the results. It looks like that. This is our clustering of stays. How we can see the agglomerative clustering was the one we decided was working best than the others, so we decided to use that. So it was very interesting for us to see that something that can be used. And we try also to have a specific description, epidemiological description of each cluster, just to be able to understand the difference between them. And we can see, for example, cluster 2 is the one with patients with the less comorbidities, and it's like a hierarchy of comorbidities between the different clusters, going from cluster 2, cluster the green one, cluster 3. After that, we are going to cluster 5, and until cluster 1, who is the more large one. And when we compare our cluster to the DRGs that are already in use and coming from the ministry, we can see that the majority of DRG for these patients are non-defined or others. This is not a DRG that is informative for us, and that was our reality. And I still using this slide to show that the DRGs do not give us the right information around the patient, and that's the reason everything is distributed this way. And we obtain an interesting labeling, and we will see. For now, we need to discuss with our group of practitioners to see if we are okay with the way the LLM is able to give a name to each cluster. And now we can automate all the process. We can just take a specific group of patients, we can cluster them, and we can have a clinical name for this cluster to understand what's going on in this type of group and why they are together. And it's very interesting because it corresponds to what we analyze right now depend on the age of the patient, the sex, the type of disease we can get. It's exactly what we obtain. This is already interesting. For the clustering of pathway, we use a signal clustering. So we want to see if, as it's a time series and it's the trajectories, we use a signal clustering to see that we have a shape-based features to help us understand the trajectory of the patient. And it's a little informative. We can clearly see that we have a difference between the four clusters we have right now. We have one that starts correctly, and after that we have a list of peaks, and after that is slowing down. And this one is starting more lately, and after that we have a regular one for cluster 3, and cluster 4 we starting correct with different peaks, and after that we are going everything is going down. So based on that, but the labeling of trajectory is a little complicated. It's not good. This is our reality. This is a distribution of for example, the cost and the length of stay depending of the type of trajectory we can have in your cluster. And our labeling is not, for now, clinically relevant. It's only shape-based. It's like you are intermittent high density burst. Okay, it's interesting, but we need to see how we can improve the clinical understanding of these trajectories of patient. So what we obtain as a result is we have something we can do. What is also interesting for us is like DRG is something very difficult to construct, but with our way of implementing things, we can automate that. And this means that it's $1 million we can preserve from as an investment. And this is something I think interesting. And finally, I also want to present what we are trying to do on clinical decision support based on our understanding of clinical reality of clinical data. I'm an ontologist, and as an ontologist, I try first to make sure that we can extract our data to the best. For example, the last presentation is based on administrative data, is already coded data and so on. But for clinical decision support, we need to go deeper than just already coded data. So what I'm using is I create first what we call the Canadian drug ontology. And this ontology for us is to standardize the way we can capture the information around the specific drugs. And we create some technical support tools around this ontology to help us extract the information of a drug, whatever the type of format we have from your data. If it's already structured, it's free text and so on, we can just extract the information on the drug and have also a specific description that can be automated. And once we have a Canadian clinical drug, we develop around the drug a specific knowledge graph. We decide that once we have a specific drug, we can have different relations between the drug itself and also the reason of the treatment and also the side effect the drug can have. And when we have this type of relation, we can also relate these diagnoses, therapeutic indication, but also side effect to a specific code. It can be an ICD code, it can be a SNOMED CT code, it can be a MEDRA code, whatever. We can just relate them. What is interesting is like a specific therapeutic indication for one drug can be the information of a side effect for another. And these, if you have this type of links that is in the knowledge, you can see when you confront them with real world data, if you can infer that, oh, okay, you are using this drug, okay, this drug has this type of therapeutic indication, maybe it's a side effect of the other one, even if nobody is saying that it's a side effect, because we already know it can be a side effect. That's our way of thinking. So we decide to create our knowledge. This is the full templates of the knowledge graph. We have a drug, it's different links with different specific indication and also different reason of using it. And we can populate that with patient information. And how we populate that with patient information is called a prescriptome. The prescriptome is coming from the common data model harmonization. It's a model that can be used to integrate data model like OMOP data model, I2B2 data model, and so on. It's developed by OMC, it's like an institution in the US that try to help us develop that. It's based on the bridge model. It's developed by the National Cancer Institute, I think. And we decide to create a subset of this common data model just to be able to describe the interaction between a patient and a specific drug. It's not very beautiful. It looks like that in reality. If you want to see what look like a knowledge graph, because it's simplified for presentation, but the reality is a little messy. But this is an example of a patient representation. Is just a subset. So if this is the way a prescriptome will look like. And based on that, we decide that we understand that LLM are not perfect and they cannot generate the true information for us. We create a consortium of researchers, industrial partners, and also non-profit organization to try to work together on the deployment, validation, and extraction of knowledge. So how we are doing that? For example, we have Wikimedica is a group of general practitioners here in Quebec that will support the description of knowledge. So for us, we are extracting knowledge coming from different sources. We can extract knowledge coming from INES, we can extract knowledge coming from the Daily Med in the US. And once we extract the knowledge, we are giving this knowledge to the team of Wikimedica that need to validate that. And the knowledge is extracted as a knowledge graph. And they can validate the information we are extracting, and this information can be shared with everybody. This is the first steps. Once everything we have our graph here and our knowledge graph that will be supported by Wikimedica. It's a website. We can just type Wikimedica and we can go online. We can have information around different disease and different treatment. Based on that, we are now working with Omnimed. Is how to say that is an electronic record system. Electronic health record system is primarily for GMF and primary care, but all their data is centralized. Because all their data is centralized, it's not depending on where we are working. We can work here in Montreal, we can work in Sherbrooke. All the information is coming into a specific cloud they are responsible of. So we try to take data coming from them. That's the reason we have a patient data graph here. And we try to now create our prescriptome. Then when we create with our prescriptome, we have now the patient reality. We have now the knowledge graph coming from Wikimedica. And now we can generate a specific LLM for recommendation. So we are not trying to create some diagnosis. We think that the diagnosis still the responsibility of a clinician, because we try and we fail. That's the main reason. And we think that the diagnosis still to remain the responsibility of a clinician. So once the clinician decides to type its diagnosis, its impression, its hypothesis, we can now propose something. And based on that, we can propose a specific treatment, we can propose a specific prevention strategy, we can propose also even a specific new encounter or a recommendation of. And this is the way we are trying to do things. So based on that, when the LLMs make a specific recommendation for a specific patient, what we are doing, we are trying to extract this information. We will extract it's not done right now, but we will extract the information for the patient and also the recommendation produced by the LLM and share it with the team of Wikimedica. We will validate the recommendation and we will be able to store this information as a way of working. For example, if you extract that, if you are with based on your age, sex, or maybe your genetic characteristic that is responsible of a specific influence of specific treatment or specific recommendation, we will extract this information and see if it's something that is meaningful that can be shared with everybody. And they will validate that and we will store this information as a knowledge graph again that will be used again in the future for integration with real-world data for our LLM to improve. That is what we are trying to do right now based on the way we decide to build things and understanding the clinical reality. So that's what I wanted to present to you. I don't know, it's going maybe everywhere, but I'm here to, if you have some questions, it will be my pleasure to respond to them.